All right, so we're going to switch gears now to a topic on GERD. And we have the pleasure of having Dr. John Clarke speaking to us next. Dr. Clarke was a former director at Johns Hopkins for the Center of Neurogastroenterology and GI Motility, but more recently has moved to warmer weather to Stanford in 2016, where he's currently the director of the esophageal program and clinical associate professor, and obviously an international expert in GERD and esophageal disorders. And he's going to be talking about new advances in GERD, as well as some diagnostic and therapeutic advances as well.
Well, thank you. I really appreciate the invitation to be here. Thank you very much. Just going to load up my screen here. Okay. And I'm going to try in the next 20 minutes to go through the key updates within the last 12 months, talk about our current diagnostic options for GERD, and then talk about the available therapies. And I've got financial disclosures here. So the first thing in terms of key updates within the last year, there's really four things which I'd like to focus on. The first one is the randomized trial, which came out in NEJM, looking at doing medical therapy versus fundoplication. Second is the FDA approval of a device that's being referred to as mucosal integrity. Third is updates upon recently concluded GERD clinical trials. There's been 3 of them which have finished within the last year. And then the fourth is I'm going to try and do rapid fire presentation of 4 papers looking at treatment and diagnosis. So this paper actually was 12 months ago today. And this is really a very seminal paper which has come out comparing medical therapy versus doing RAPs for those patients that have GERD. This was set within a VA group. And what they did is actually a randomized control trial. They took patients who had GERD symptoms despite taking a PEPI twice a day. It was a reasonably involved protocol. And so they put everyone upon 20 BID of omeprazole and did that for at least two weeks. Then they did endoscopy biopsies plus also manometry and pH impedance. And for everyone that had symptoms that continued despite the PEPI trial, and keep in mind these were patients referred because of GERD, which was at baseline refractory to PIs. Then they at that point randomized them going towards surgery versus aggressive medical therapy. And the medical therapy was twice a day PEPI plus baclofen plus a TCA. And their main outcome was greater than 50% improvement in symptoms at 1 year. And there were 2 key findings which came out of this study. The first one was that most patients in their series who were referred because of refractory GERD symptoms, despite a PPI, didn't actually have GERD, which was refractory. So they looked at 366 patients, but by the time they excluded patients who felt better with regards to doing a PEPI trial, or had significant dysmotility, or had some other diagnosis besides GERD, they actually were only left with 78 patients. And so it was a little less than 1 in 5 that actually met the criteria. And then the second is that in that subgroup that actually had documented refractory GERD, these patients did much better with surgery than with medical therapy. Second thing which I'd like to talk about is this tool which was just FDA approved. And the name for it is mucosal integrity, but it's really the same thing as mucosal impedance. And so as background with this, we've had the ability to look at impedance within the esophagus since the late 1990s. And it's been seen as being a marker of permeability and flow. And the group based in Nashville hypothesized, well, if we could take this information that we get from the 24-hour pH impedance studies, what if we could make a device and look at this in real time and actually measure the wall of the esophagus? Would it be possible to look at permeability there and use that as a marker of change, including EOs or else GERD? And so they ended up building a real-time device, which has evolved with time. At first, it was just one sensor. Now it's actually um, um, uh, two strips of 10. And so on the left-hand side, you see this when it's deflated. And this can be placed through a scope itself. And then on the right, you see it when this becomes in inflated. And what it's doing is it's lining these sensors up against the wall of the esophagus and actually looking at the permeability in that area. And what they reported is that in their series, they could separate people who are healthy controls versus GERD versus EOE. And if they looked at different points along the esophagus and different patterns, it was possible to separate these more. So what they're hypothesizing is that this device in real time may give information that correlates well or perhaps better than doing studies which are 24 hours or longer. And that maybe this information that you get in real time during endoscopy will obviate the need to then do additional pH studies. Now, we'll have to see where this plays out with time. It's FDA approved now, and so we will be seeing this in years to come. But the groups that they studied were very well separated. And so I think in those patients with clear GERD or EOE that's very clear, or else normal, it's likely that this separates well. But as you all know, the people that we see in clinic, there's often a lot of vagaries in what they have, and if this is GERD or normal or EOE or functional, and it's unclear in more of these gray areas how well this will separate it. So I think something to know about, something to keep an eye out for. We'll see how this may change practices in years to come. Third thing I wanted to update upon recently finished clinical trials, and there's been 3 main trials which have finished within the last year. And unfortunately, all 3 of them really were appear to be negative studies. The first one, which was looked at, was the Endostim study. This was a implantable stimulator, which was designed to try and augment pressure in the LEES, and this did not meet its endpoint, despite large enrollment at 17 centers. Second was Nectar, which is in the bottom 2 picks there. And this was actually a device looking at doing bulking of the LES. This one closed based on safety concerns. And then the third one is an Ironwood study looking at a bile acid sequestrant. And this also just recently closed as well and did not meet the endpoint. And now in rapid fire, I'd like to go through 4 papers which I thought were fascinating within the last year. First one, just to give a shout out towards George T, who is talking tomorrow. He had really developed this concept, and what he had looked at was, we often recommend diet with GERD, but quite frankly, there's not great data as to how much of a benefit that makes. And so he had seen that we're now doing mostly 96-hour pH studies. And what if we could put patients upon their baseline diet the first 48 hours and then restrict the diet the last 48? And could we see a difference with that? And so in his series, what he found is that of those people who had GERD in the first 48 hours, and when he placed them upon a very restricted diet, 2/3 of them actually had a big change with acid in the last 48 hours, which became normal. So I think that where this leaves us is A, we have better evidence diet works. B, we can use this particular 96-hour study as a means of also testing different therapies. So if we get a 48-hour baseline and look to see if they have GERD or not GERD, then we can use that next 48 hours and look at diet or medications or other things along those lines and see if these interventions work. Second one to go through was this randomized control trial looking at Stretta. And Stretta has been one of those devices that I've scratched my head on for about 20 years. And it's been FDA approved since 2000. But the data hasn't been, I think, as robust as we'd like to see. And there's been a real question as to, who are the patients that really benefit from this? And so the group in France looked at doing a randomized controlled trial of doing Stretta versus sham, and had 62 patients. And unfortunately, the response rate with sham was 15%, and with Stretta it was 3%. And they didn't see any change in PPI use, any change in heartburn, and no change also in pH impedance. The third one I thought was fascinating. This is from the Japanese group, and actually the same person who had really pioneered POEM is also pioneering this as well now. And what he's doing is he's doing what he refers to as an anti-reflux mucosectomy, where he's doing essentially an ESD in the upper stomach to try and induce scar tissue, and then use that to try and contract the EGJ. And there's been a number of small case series which have looked promising, but it's sometimes hard to know what to make of an N of 10, an N of 15, et cetera. And so this is the first more long-term follow-up within a size that seems decent. Numbers were a little vague in the paper, but it looks like most patients are doing well year out. And it seems to be pretty safe in his hands. So where this will go with time, if this will make it towards the States, I think we have yet to see. But I think it's interesting and something to keep an eye out on. And then the fourth one I want to talk about is this study that looked at doing LINX implants versus PEPIs for treating regurgitation specifically at 1 year. This was a large study. They had 20 sites involved. And they reported that the rates of success with LINX were 96%. The rates of success with a PPI were only 19. Now, in some ways, this was a study stacked to make the operation look a lot better, because we know from the medical standpoint that a regurgitation is really the one symptom that we don't get better with medical therapy. We get heartburn better, but in terms of regurgitation, we don't see as much improvement with that. So not surprisingly that the operation looked a lot better, but I think this is another paper reinforcing the fact that in patients who are well selected, LINX can be a very reasonable option. In this particular series, the acid exposure time decreased from 10% to 1%. They had 7% dysphagia, 25% bloating. So I'll turn here and talk about the diagnosis of GERD right now in 2020. And if you think about it, reflux is really a process that we all have to have. If we couldn't have any reflux whatsoever, we'd have bloating, distension, we feel miserable. So this is really a process which is normal, which is required to gas vent. And most times we see esophageal acid exposure of less than 4%. And then reflux, if we do testing with impedance and look at the numbers, we see some throughout the day, but they're generally less than 40. And we have a number of mechanisms which are at play to prevent reflux from that inducing issues. We have a sphincter, we have funded compliance, we have a diaphragmatic pinch, secondary peristalsis, salivary production, frequent swallowing, as well as mucosal barrier functions. And so it takes a lot to break that down, and it's often not as simple as one pathway alone. And if we use that as background, when we see patients with GERD, the first step is usually response towards medical therapy, with the idea that if acid is thought to induce symptoms, then doing medical therapy to block acid is both diagnostic as well as therapeutic. And this also makes sense because we do see GERD symptoms within 20% of the population. So if we were to go and do testing with doing endoscopy, pH testing, et cetera, in 20% of the United States, we would bankrupt the system pretty quickly. And most people, it's not necessary. Now, if they have symptoms that continue despite that, or they have warning signs, then at that point, the next step is typically endoscopy. And with endoscopy, you're really doing it for two purposes. One is to look and see if there's any consequences of GERD, if you have Barrett's or anything along those lines. Then the second is to make sure we're not missing anything else. Is this EOE? Is there a giant hernia? Something along those lines. But it's important to recognize going in that the sensitivity of doing an upper endoscopy for a diagnosis of GERD is only between about 10 and 20%. So most of the times that you're doing an upper endoscopy for GERD, it's going to come back looking pretty normal. And then the question is what to do next. And traditionally, we've had two possibilities at this point. The first one is wireless pH testing. The second is pH impedance. And then now with this recent approval, as well of mucosal integrity, we do have a third option. But again, we'll see where that plays out with time. If we take a look at wireless pH testing versus pH impedance, there's pros and cons of both. And I personally don't think that one of these is necessarily better than the other. I think it comes down to what question is being asked and what other tests that they have going on. If you look at wireless pH testing specifically, this can be done with endoscopy. And so if you're doing endoscopy anyway, it takes about 2 extra minutes to add on. You don't have to have tubes, wires, catheters. You can look for 96 hours, which is nice. Because it's not visible, they still can exercise, be at work, restaurants, things along those lines. So perhaps the information you get is more physiologic, and it does appear to be something patients like. The downside of it is that you're only looking at acid. So if your fear is non-acid, you won't pick it up in this case. You're only looking at one point. So if someone, for instance, sips a soft drink throughout the day and doesn't tell you, you can't separate what's a reflux event and what's a swallow. You are forced to choose on or off therapy with the 48 hours, with a shorter studies. With 96, maybe that's less of a factor. It is more expensive. It does require endoscopy. In terms of pH impedance, you can look at both acid and non-acid. You can separate swallows from GERD. You can look at how high it's going, which perhaps is relevant in cough and pulmonary issues. You can look at the movement of air, which may help in terms of belching. You don't have to have endoscopy. So if you weren't planning on doing endoscopy anyway, you can do it without it. It's cheaper. But the downside is that it does require a tube coming out the nose. It is limited towards 24 hours, and it's kind of a pain to read. If you're reading a wireless probe, you can sit down and take a look and fully feel very comfortable with that study in about 30 seconds. With doing a pH impedance, you're probably looking at 20 to 30 minutes. Now, in my own practice, I'd say I probably do 60% wireless, and I'd say the rest are pH impedance. Now, we've had 2 guidelines within the last 3 years that have come out looking at how exactly to do these testing. And there's been two points that they've tried to go through and answer. The first one is, do you test on or off therapy? And this is a question that always comes up. And what they've recommended is that if you have documented GERD, meaning that you've had a prior endoscopy with grade C or D esophagitis, Barrett's esophagus, or else any peptic stricture, or if you've had prior testing off meds, which is positive, then you should test on meds. If you don't meet any of that criteria, then it's best at that point to stop meds and test off. If you interpret it, GERD is probably not a binary yes or no. And I think there's much more of a spectrum. There's some people who may have LAD esophagitis and 20% acid exposure. It's not going to be the same thing as a patient who has 6% and no change with endoscopy. But what they've attempted to do is to characterize these patients into those who definitely do have GERD, definitely don't have GERD, and then that middle category where doing additional testing could help. And the group that they say definitely does is the group that has LAC or D esophagitis, peptic stricture, Barrett's esophagus, or has acid exposure time of greater than 6 off meds. The group that's definitely normal is where there's no esophagitis and acid is less than 4. And then in the middle is a bit of a gray area where you really have to look at that on a case-by-case basis and then think about some of the other tests which we have. And the end goal of all of this is to separate these patients into a couple clinical buckets that you then can tailor therapy for. And what you're looking for is to see, is this reflux? Is this more of a reflux sensitivity? Is this functional? Is this an overlap? And making that a clinical diagnosis can then help you triage what to do as the next step in terms of therapy. Now, in terms of treatment, To go back to the prior talk, which I had about multiple mechanisms, there's some people that have GERD secondary to hernias. Some it might be just be more of dysmotility, and they're not clearing what comes up. And so a lot of different mechanisms can factor into GERD symptoms. And so not surprisingly, it's not one size fits all in terms of therapy. And the goal is really to try and tailor what therapies that we can offer based on what we think is going wrong. And so a brief summary of the options that we have now are lifestyle modification, medications, CAM, then therapy mechanically with both endoscopy and surgery. If we step back and look at lifestyle modification, there's a long list of things which are mentioned. I'll say in my experience, I think the ones with the best data are first off, weight loss, if that's a factor. And it doesn't have to be a lot of weight, typically 5 to 10% is typically adequate. And then if they have nighttime symptoms, raising the head of the bed, and then cutting meals out within about 3 hours of sleeping. There's a lot of dietary foods which are listed to avoid, but the bottom line is that these are really based on more case series. There's not great evidence that if you don't have GERD triggered by these foods, that cutting these foods out helps. And in fact, some of them may work through some mechanisms and not some. If you look, for instance, like chocolate or caffeine, these two have both been shown to increase the frequency of how often the LES will in fact open, but they also accelerate gastric emptying. So some people may have more GERD based on that, based upon the LES parameters. Some people may have less because their stomach emptying is faster. So I think it really depends upon the person and their own, I'd say their own trigger specifically. In terms of medical therapy, the first step really is trying to block acid, and we have 3 options of doing that. If we step back and look at this, the PPIs are by far the best option that we have in terms of blocking the acid, but they're also the slowest acting, the most expensive. In terms of other meds that we sometimes will do, there's a list of complementary meds which are here that we sometimes will do on a case-by-case basis. But I just want to emphasize that in most people, the relative benefit that you're getting from this category is more minimal than that prior slide which I showed. And I think the one that I'll talk about specifically are the first group, the alginates. These are these have gotten more attention within the last 3 years as there's been more worry about potential PI adverse effects and more interest in doing therapy which is perceived as safer and more natural. And the background of these are that these are seaweed derivatives that basically can be combined with food or antacid to try and thicken the gastric acid. It's a little bit unclear if the mechanism is from thicker fluid that doesn't go up as high, or if there's a raft-like function that's on top that may prevent contact via the esophagus. Bottom line is that they do appear to have a modest benefit. And where I find them to be helpful is if people have mild symptoms despite a PPI and want something else to take, or if they really want to get off meds which are perceived as potentially risky long term. This is something that can be done with meals, after meals, and does appear to be safe and somewhat effective. There's a long list of different complementary therapies which are out there. And I won't go through each of these in turn, but there was a nice paper from Ronnie Foss and his group in 2007 that looked at treating patients with GERD with acupuncture. And they actually had fantastic results with it. These are very tough studies to do just because no one funds them. But for those patients who do want something that's non-medical, this is a good option. There's also literature looking at herbs as well as pre and pro biotics as well. And then we turn towards therapies that are mechanical. And if we look at these, we do have options with both endoscopy and surgery. Stretta, I had talked about a little bit before, and so I won't go more into that here, as well as the ARM technique. TIF and LINX are really both targeted at present, one with endoscopy, one via the OR, at situations where you can increase sphincter pressure and increase the EGJ in situations that you don't have a big hernia and motility is pretty normal. So I think my sense is that they're really going after the same group in that scenario. Both of them, I think TIF has a decent short-term follow-up. We'll see long-term where that goes. I know there's a few sites in the Bay Area doing it. And I think, we'll see what the long-term approach of that is, but a short-term, it looks promising. In terms of surgery, we've had Nissen since 1954 at this point. It's been laparoscopic since 1992, and that's probably the mainstay of therapy at present. LINX is more new, but what we have so far in the 5-year follow-up looks pretty good. My sense is that the main benefit of that is that there's perhaps less experience necessary to do it. It's more of a one-size-fits-all, and it may allow one to still belch as well afterwards. But it's probably best for those patients who don't have hernias, who have a pretty good peristalsis as well. And then for those who have a BMI that's high, a Roux-en-Y is also an option that's worth thinking of. So I'd just like to end by just thanks to everyone in our group. Part of why I moved here was this group here, and I think we have a great center. And if there's patients that we ever can help with at all, I've got my cell here, and please reach out if you want to chat about cases or anything along those lines. So well, thank you very much. I really appreciate the invite, and thank you.
Thank you, John, for that very informative talk. We do have a question under alternative treatment. Why are people still recommending apple cider vinegar? If there's any merit to this, and does it help with acid control?
Yeah, that's a great question. I don't know of any studies which have looked at this, and my I did a lit search on this a few years ago. I didn't find anything. At first, it made no sense to me whatsoever, because if GERD is secondary to at least partially higher amounts of acid, I don't know why giving acid would help in that scenario. Now, I've since rethought this, and I think the mechanism is that the most potent suppressive of gastric acid that we have right now is acid. And so one of the things that we see is if you have chronic acid suppression, your gastro increases, and then it's very hard to get off these meds. So maybe vinegar is possibly suppressing the acid production because it is acid in nature, and the amount of acid that you're doing, or that particular form, may be less injurious than possibly gastric acid. So there's at least some basis that is there in physiology. I've had patients swear it works really, really well, but as far as I know, there isn't any literature on it.
Thank you. We also have another question about what you're telling PCPs and patients about long-term use of PPI. Just to snowball on that, the newest thing is PPI and risk of COVID complications, which recently came out. And personally, myself, seeing a lot of patients with normally pretty well-controlled symptoms on low-dose PPI who have, either borderline or minimally high acid exposure time around 6% and are doing pretty well, but are more reaching towards, which TIF, which seems like the most promising kind of treatment for these patients. And so just wanted your thoughts.
Yeah, that's a great question. And, I purposely didn't put that in the talk because it would have sent me way over the time limit. But I think, it's a great question. There's two ways of thinking of it. I think that the data with regards to PPI adverse effects are all based upon low grade and weak evidence. And we don't have any good long-term information suggesting that these necessarily induce issues. These are drugs that have been FDA approved now since 1990. The sales within the US per year alone are greater than a 15 billion. And if there was a giant smoking gun, I would have thought we would have seen it by now. Now, the flip side of that is that we know that the PPIs do have effects within the microbiome. There have been, to my knowledge, no studies looking at long-term effects of PPI use beyond approximately 4 years. And for a lot of these patients with GERD, for instance, who are in their 20s, and we expect them to live 60 plus years, I can't tell them with 100% confidence that this is necessarily in their best interest. So I think the take-home point for us is that we want to make sure that if they're on it, that they need to be on, and that we find the dose that works, which is lowest. Now I've had the same experience with you where I've seen patients who have come in who had LAD esophagitis, who had strictures, who have flares because they switched towards Pepcid. And, obviously that won't cut it. In that patient, PEPI is definitely necessary. But I think this is a gray area that's still emerging. And I think my sense is that it is probably a safe med. But I think the goal is to find the lowest dose that works. And if they can safely get off, then I think that's reasonable. There was one paper a few years ago that asked different experts if they had a choice of being on high doses of PPIs long-term twice a day versus doing an operation, which they'd want. And in that study, the vast majority of them wanted medical therapy instead of an operation. But I think now with these concerns about the adverse effects of PPIs, with LINX and TIF coming out and other options which are there, I think that pendulum's shifting. I think we'll see where time takes it, but this is not as clear an answer as it was before.
Yeah, I think a lot of the patients with milder symptoms do well with intermittent PPI therapy as well, and some of these new, more potent potassium acid blockers. We'll see if that can even allow for even more intermittent therapy. Yeah. And then maybe just one more question. It looks like Reflux Gourmet is based in Napa. Have you had any patients use it or have any benefit from it?
So, I've had a few patients now who've said that they really like it. I have not had, I can't say I've had any contact with the company itself. I've tried to look them up, and it looks like you can only buy it via Amazon.com. I don't think it's possible to go and check it out there. I've been curious actually to visit just because it's Napa and it'll be fun to make it up there. But I don't recollect seeing any papers with it. I've had patients though who have really liked it. What's kind of nice about that too is that they do have different flavors. So if you want chocolate, for instance, or also vanilla, caramel, things along those lines, it's probably a more palatable way of doing it than the Gaviscon double action.
And then I guess one last question, sorry. For your bariatric patients, it seems majority have been moving towards sleeve, and what we're seeing now is a lot of post-sleeve reflux. And are you working with your bariatric surgeons to hopefully identify some of those patients who are at risk for post-sleeve GERD?
Yeah, we are. I mean, this ends up becoming much like the PPI use. It's kind of I'd say it's more of a story that's being told. There are some groups that are doing reflux testing in all patients before bariatrics. We aren't doing that now. But I think that's one way the groups have gone after it. We have been seeing that as well. There has been some interest in maybe doing stretta after these, just because it is something which you could do with endoscopy. There's also I think there's been questions of LINX after as well. But for most of these patients, we end up converting them towards a RU in that scenario. But I think this story is being told.
Great. Thank you very much, John, for an excellent
Thank you.
talk.
Appreciate the invitation.